It's 2 a.m. You wake up scratching. Your skin burns with an inexplicable itch that no amount of scratching relieves. You check for mosquito bites, bed bugs, new laundry detergent, nothing. You scratch until your skin bleeds, finally exhausting yourself back to sleep. Tomorrow night, it happens again. Most people dismiss nighttime itching as dry skin, allergies, or stress. They buy moisturizers, antihistamines, and new sheets. But for some, that relentless midnight itch is their body's desperate warning that something serious is wrong deep inside. As a physician, I've diagnosed life-threatening conditions from a single symptom, nocturnal pruritus, the medical term for nighttime itching. I've seen patients scratch themselves bloody for months before discovering they had lymphoma, liver failure, or kidney disease. The itch wasn't in their skin. It was a signal from failing organs, circulating toxins, or malignant cells releasing inflammatory mediators. Understanding when nighttime itching crosses the line from benign annoyance to medical emergency can literally save your life. Let me explain the science behind why we itch at night, what makes it worse, and most importantly, when that itch is screaming that you need to see a doctor immediately. Before we discuss pathological causes, let's understand why even healthy people itch more at night. This isn't imagination. It's real, measurable, and rooted in circadian biology. Circadian rhythm of inflammation. Your body's inflammatory processes follow a 24-hour cycle. Cytokines, the signaling molecules that trigger inflammation and itching, peak during nighttime hours. Interleukin-31, specifically implicated in chronic pruritus, shows elevated levels between midnight and early morning. This evolutionary pattern may relate to wound healing, which accelerates during sleep. Cortisol fluctuations. Cortisol, your body's natural anti-inflammatory steroid, follows a diurnal pattern. Levels peak around 8 a.m. and gradually decline, reaching their lowest point around midnight. This nadir in cortisol reduces your natural itch suppression, precisely when inflammatory mediators peak, creating a perfect storm for nocturnal itching. Temperature regulation. As you prepare for sleep, your body dilates peripheral blood vessels to dissipate heat, dropping your core temperature. This vasodilation increases skin blood flow, warming the skin. Warmth is a potent itch trigger, activating the same nerve fibers that transmit itch signals. Reduce distractions. During the day, your brain processes countless stimuli: visual input, conversations, work tasks, movement. These competing signals suppress itch perception through a phenomenon called central gating. At night, in darkness and quiet, itch signals face no competition. Your brain amplifies what would be minor daytime itching into overwhelming nighttime torture. Transepidermal water loss. Your skin loses more water at night, particularly under blankets and heated rooms. This nocturnal increase in transepidermal water loss dries the stratum corneum, the skin's outermost layer, lowering the threshold for itch activation. These normal physiological factors explain why healthy skin itches more at night, but they also amplify pathological itching, making nighttime scratching a particularly sensitive indicator of underlying disease. Certain characteristics distinguish benign nighttime itching from medical emergencies. As a physician, I evaluate several key features. Distribution pattern. Generalized itching affecting the entire body, particularly without visible rash, is concerning. Localized itching usually indicates dermatologic causes: eczema, contact dermatitis, fungal infections. But whole body pruritus without skin lesions suggests systemic disease affecting your entire physiology. Severity and impact. Benign itching is annoying. Pathological itching is life-disrupting. Patients describe it as unbearable, like insects crawling under my skin, or worse than pain. They scratch until they bleed, lose sleep for weeks, develop depression and anxiety. One patient told me, "I would rather break my leg than feel this itch for one more day." That level of suffering demands investigation. Associated symptoms. Isolated itching rarely indicates serious disease, but itching plus other symptoms creates diagnostic patterns. Night sweats plus itching suggests lymphoma. Jaundice plus itching indicates liver disease. Weight loss plus itching raises concerns for malignancy. Dark urine and pale stools with itching point to biliary obstruction. Temporal pattern. Acute itching developing over days typically indicates allergic reactions, infections, or new exposures. Chronic itching persisting for weeks or months without clear cause demands comprehensive evaluation for systemic diseases. Response to treatment. Benign itching improves with moisturizers and antihistamines. Pathological itching doesn't. Patients buy every cream, take double-dose antihistamines, try elimination diets. Nothing helps. This refractoriness is a red flag. Now let's explore the serious medical conditions that manifest as nighttime itching, starting with the most feared. Hodgkin lymphoma. This blood cancer has a pathognomonic symptom, severe, intractable pruritus affecting the entire body. Approximately 30% of Hodgkin lymphoma patients experience pruritus, and for 10 to 15, it's the presenting symptom before any other manifestations appear. The mechanism involves cytokines released by malignant Reed-Sternberg cells, IL-31, IL-6, and TNF-alpha. These inflammatory mediators activate itch receptors throughout the body. Patients describe it as deep, burning, and impossible to satisfy. Scratching provides no relief because the itch originates from circulating inflammatory molecules, not skin pathology. Classic presentation. A young adult with unexplained, severe nighttime itching, drenching night sweats, unconditional weight loss, the B symptoms, and painless lymphadenopathy. The lymph nodes often feel rubbery and are typically in the neck, armpits, or groin. Other hematologic malignancies, non-Hodgkin lymphoma, leukemias, and multiple myeloma can cause pruritus through similar cytokine-mediated mechanisms. Polycythemia vera, a disorder where bone marrow produces too many red blood cells, causes characteristic aquagenic pruritus, intense itching triggered by water contact, particularly warm showers. Patients emerge from the shower desperately scratching, sometimes for an hour. Solid tumors. Cancers of the lung, stomach, colon, breast, and prostate occasionally cause paraneoplastic pruritus. The tumor releases substances that trigger systemic inflammation and itch. This is rare but represents one mechanism by which internal cancers manifest externally. The key point: unexplained, severe, generalized itching persisting beyond 6 weeks warrants evaluation, including complete blood count, comprehensive metabolic panel, and potentially imaging to exclude malignancy. Liver disease produces some of the most severe, intractable itching in medicine. The mechanism involves cholestasis, impaired bile flow. Bile acids, normally secreted into the intestine to aid fat digestion, accumulate in the bloodstream when bile flow is obstructed. These bile salts deposit in skin tissues, triggering intense pruritus. Primary biliary cholangitis, PBC. This autoimmune disease destroys small bile ducts within the liver. Patients, typically middle-aged women, develop progressive cholestasis. Pruritus is often the first symptom, appearing years before jaundice or liver failure. The itching is severe, generalized, and classically worse at night. Patients scratch until they bleed, develop insomnia, depression, and suicidal ideation from the unrelenting torture. Diagnosis requires anti-mitochondrial antibodies, AMA testing, and liver biopsy. Treatment includes ursodeoxycholic acid to improve bile flow, cholestyramine to bind bile acids in the intestine, and newer agents like bezafibrate or obeticholic acid for refractory cases. Primary sclerosing cholangitis, another cholestatic disease affecting larger bile ducts, often associated with inflammatory bowel disease. Produces similar severe pruritus through bile acid accumulation. Obstructive cholestasis. Gallstones, pancreatic tumors, or strictures blocking the common bile duct cause acute cholestasis. Patients develop jaundice, yellowing skin and eyes, dark urine like tea or cola, pale clay-colored stools, and severe itching. This represents a surgical emergency requiring intervention to relieve the obstruction. The pattern here is crucial. Itching plus jaundice, dark urine, or pale stools means liver or biliary disease. This requires immediate evaluation with liver function tests, ultrasound, and possibly MRCP, magnetic resonance cholangiopancreatography, to visualize bile ducts.
Chronic kidney disease produces pruritus in 40 to 90% of dialysis patients and 15 to 49% of pre-dialysis patients. The itching can be localized or generalized, often affecting the back, face, and arms.
The pathophysiology is multifactorial and not completely understood. Contributing factors include uremic toxins. As kidney function declines, metabolic waste products accumulate. These uremic toxins, including urea, creatinine, and various organic compounds, may directly activate itch receptors or trigger inflammatory cascades. Xerosis, dry skin. Kidney disease impairs the function of sweat and sebaceous glands, reducing skin hydration. The uremic environment also affects skin barrier function, increasing transepidermal water loss. Secondary hyperparathyroidism. Failing kidneys cannot activate vitamin D or eliminate phosphate. This disrupts calcium phosphate balance, triggering excessive parathyroid hormone secretion. Elevated PTH and calcium phosphate product deposition in skin contributes to itching. Immune dysfunction. Chronic kidney disease alters immune function, increasing circulating inflammatory mediators and mast cell activation in skin. Neuropathy. Uremia affects peripheral nerves, potentially causing neuropathic itch signals. Treatment involves optimizing dialysis adequacy, correcting mineral imbalances, using emollients, UVB phototherapy, and medications like gabapentin or pregabalin for neuropathic components. In some cases, kidney transplantation is the only definitive cure. The diagnostic clue: itching in someone with known kidney disease or risk factors, diabetes, hypertension, family history of kidney disease, warrants checking creatinine, estimated GFR, and urinalysis. Hyperthyroidism. Overactive thyroid increases metabolic rate, skin blood flow, and body temperature. Patients often feel warm and sweaty, which exacerbates itching. Additionally, hyperthyroidism can cause urticaria, hives, and generalized pruritus through immune-mediated mechanisms. Hypothyroidism. Underactive thyroid reduces sebaceous gland activity, causing severe dry skin, myxedema. The resulting xerosis triggers itching. Patients also have slowed cellular turnover, accumulating dead skin cells that physically irritate. Diabetes mellitus. Multiple mechanisms cause itching in diabetics. High blood glucose increases skin glucose, feeding fungal and bacterial organisms that cause infections, candidiasis, bacterial folliculitis. Diabetic neuropathy can cause scaly patches on the shins. And poor circulation reduces skin health. The pattern is itching plus symptoms of thyroid disease, weight changes, temperature intolerance, fatigue, palpitations, or diabetes, thirst, urination, blurred vision, warrants checking TSH, glucose, and hemoglobin A1C. Itch isn't always about skin or systemic disease. Sometimes the problem is in the nervous system itself. Neuropathy itch. Damage to peripheral nerves from diabetes, shingles, nerve compression, or multiple sclerosis can cause localized, intense itching in the distribution of the affected nerve. Brachioradial pruritus affects the forearms from cervical spine nerve impingement. Notalgia paresthetica causes intractable itching on the upper back from thoracic nerve entrapment. These conditions produce itch without rash in specific dermatomal patterns. Diagnosis requires recognizing the neuroanatomical distribution. Treatment targets the underlying neuropathy with medications like gabapentin, pregabalin, or topical capsaicin to desensitize nerve endings. Central sensitization. Chronic itch can rewire the nervous system, creating persistent itch signals even after the original trigger resolves. This is similar to chronic pain syndromes. The itch becomes its own disease, requiring neuromodulatory approaches. While less common in developed countries, parasitic infections remain important causes of nocturnal pruritus globally.
Scabies? The mite Sarcoptes scabiei burrows into skin, laying eggs and triggering delayed hypersensitivity reactions. The classic presentation is intense nighttime itching with burrows visible between fingers, on wrists, elbows, and genitals. The itch worsens at night because the mites are more active in the warmth under blankets. Pinworms. Common in children, these intestinal parasites migrate to the perianal area at night to lay eggs, causing intense anal itching that wakes children from sleep. Onchocerciasis, river blindness. In endemic areas, this parasitic infection causes severe pruritus as adult worms produce microfilaria that migrate through skin. These diagnoses require clinical suspicion based on exposure history and characteristic findings. Treatment involves specific antiparasitic medications. Atopic dermatitis, eczema. This inflammatory skin condition involves skin barrier dysfunction and immune dysregulation. The circadian rhythm of inflammation means eczema naturally worsens at night. Patients develop sleep disruption from scratching, which perpetuates the disease through stress and sleep deprivation. Psoriasis. While typically causing scaling more than itching, some psoriasis patients experience significant pruritus that follows circadian patterns. Contact dermatitis. Allergic reactions to fabrics, detergents, or skincare products may not manifest until nighttime when skin warms under blankets and increased blood flow delivers more allergen to immune cells. The key distinguishing feature, these conditions produce visible rashes. If you see eczematous patches, scaling, or redness, the diagnosis is primarily dermatologic. If your skin looks normal but itches severely, think systemic disease. The brain and skin communicate bidirectionally through the psychoneuroimmunologic axis. Stress, anxiety, and depression can manifest as or exacerbate pruritus. Chronic stress elevates cortisol acutely but can cause cortisol dysregulation chronically, disrupting the normal anti-inflammatory rhythm. Stress also triggers mast cell degranulation, releasing histamine and other pruritogens. Psychogenic pruritus. In some patients, the itch is purely psychological, with no identifiable physical cause. This is a diagnosis of exclusion requiring ruling out all organic causes first. Depression and pruritus. These commonly coexist bidirectionally. Chronic itching causes depression through sleep disruption and reduced quality of life. Depression lowers itch threshold through altered neurotransmitter balance. Treatment involves addressing mental health with therapy and medications, like SSRIs, which have both antidepressant and antipruritic properties. Seek immediate medical evaluation if you experience generalized itching without visible rash, persisting beyond 2 weeks. Nighttime itching disrupting sleep consistently. Itching accompanied by jaundice, dark urine, or pale stools. Unexplained weight loss, fever, or night sweats with itching. Itching plus enlarged lymph nodes. Itching with fatigue, cognitive changes, or decreased urination. New medications started recently. Many drugs cause pruritus as side effect. Failure to respond to moisturizers and antihistamines. These patterns warrant comprehensive evaluation. Complete blood count, checking for blood disorders. Comprehensive metabolic panel, liver and kidney function. Thyroid function tests. Chest X-ray, screening for lymphoma or sarcoidosis. Consider HIV testing in at-risk populations. Potentially imaging or biopsies based on clinical suspicion. Treatment depends on the underlying cause, but general principles include: treat the root cause. This is paramount. Cholestyramine for cholestatic pruritus, dialysis optimization for uremic pruritus, chemotherapy for lymphoma. Skin barrier protection. Even in systemic causes, maintaining skin integrity reduces itch. Use fragrance-free emollients immediately after lukewarm, not hot showers. Avoid harsh soaps. Humidify your bedroom. Antihistamines. First-generation sedating antihistamines, diphenhydramine, hydroxine, work better for nighttime itching than newer non-sedating versions. They provide antipruritic effects plus sedation to improve sleep. Neuromodulators. Gabapentin and pregabalin effectively treat neuropathic itch and have shown benefit in uremic and cholestatic pruritus. Immunomodulators. Topical steroids for inflammatory causes, systemic immunosuppressants for severe atopic dermatitis. UV phototherapy. Narrowband UVB light helps many chronic itch conditions by modulating immune function and skin biology.
behavioral interventions, habit reversal therapy to break scratch itch cycles, stress management, cognitive behavioral therapy for sleep disruption. That midnight itch keeping you awake is your body's communication system. Most of the time, it's harmless. Dry winter air, new sheets, or circadian biology amplifying normal sensations. But sometimes that itch is an alarm bell, your organs screaming for help in the only language they know. The art of medicine involves distinguishing between the benign and the dangerous. Generalized itching without rash, severe enough to disrupt sleep, persisting beyond a few weeks, or accompanied by systemic symptoms like weight loss, jaundice, or fatigue, demands investigation. Don't let embarrassment or dismissiveness prevent evaluation. I've had patients scratch for years before seeking help, suffering needlessly while treatable conditions progressed. One patient told me, "I thought the doctors would think I was crazy, complaining about itching." By the time she was diagnosed with primary biliary cholangitis, she had advanced liver disease. Your skin is your largest organ, intimately connected to every system in your body. When it whispers at night through persistent itching, listen. That whisper might be saving your life.